Good afternoon, everyone. How are y'all today? Yeah? So we're going to do several things today. We're going to continue where we left off. You're going to learn about benefit groups and a whole lot more about benefit groups today. We're also going to do some cases to practice because with therapy, with pharmacotherapy, up until now, getting everything memorized, okay, has led you all to success on a test, right? If you get all the facts memorized, you should be successful on a test. What happens in pharmacotherapy is that's the first step, not the final step. Because not only do you have to have the things memorized that you need to be successful, you have to know how to use that knowledge, okay? And that takes practice, and that's why we're going to be doing some cases a little bit later on today to give you practice using this knowledge that we're providing you. All right, so trying to build a skill set here so that you can be successful on the exam. Before we go further, though, I would like everybody to whip out a blank sheet of paper or a blank screen so that they can write things down, because I have a quiz for you. I would like you to list the traditional risk markers. Yep, list the traditional risk factors for lipids that I gave y'all last time. Yep, they are for cardiovascular disease. Everybody needs to do it. I know y'all are pretty much brain dead. You had a test yesterday. But everybody needs to write down what they think those traditional risk markers are. You know that you're starting to get ready for the exam when you can do this in 1 minute or less. I'm not kidding. I wish I was kidding, but I'm not kidding. You have to be really fluid on this kind of stuff. All right. Has everybody gotten as far as they can? All right. I want you all to compare your list to a friend's. All right? Compare your list to a friend's. See if you can get it more complete. So compare your list to a friend's. Just have a seat, unless you want to just move around. Okay. I'm only giving them like 30 seconds for this. Have we got them? All right. 5, 4, 3, 2, 1. Time's up. All right, so here we go. So who got age? All right. What is it in men? 45. What about women? 55. Did anybody get premature family history? All right. What is it in a first-degree male relative? 55. How about a first-degree female relative? That's right. 45, 55, 55, 65. Who got being male? Okay, very good. Who got smoking or tobacco products? Okay. Who got diabetes? How about high blood pressure on antihypertensives? Okay, that's one a lot of people missed. All right. What about total cholesterol greater than 200 or HDL less than 40? Who got that? Oh, we missed that one except for one. All right. Sorry, two. I apologize. There were 2. I did mention I was blind, right? Okay. So, if you didn't have this list, Complete your list at this time. That's your first study guide. Congratulations. You've got your first study guide. Well, the application of it will be on the test. I won't ask a question such as, what are the traditional risk markers? You'll have to know what they are so that you can answer a case about them. Okay? Memorization is the first step. That's right. Okay. So with that, here we go. Jack slides. Is that for you? All right, hold on. Ladies and gentlemen, it is my absolute and utter pleasure to introduce you to Dr., soon-to-be Dr. Jack Thomas. All right? He is in his very last day of his academic rotation with me. So this is the end of a 10-week block because he spent 5 weeks with me in my AmCare clinic, and now he spent 5 weeks with me learning how to teach. So he's been like living diabetes, breathing diabetes, ready to kill himself over diabetes. But today we're all about lipids, okay? So I hope you will give him a warm welcome. Please note that at the end of his presentation, I'm going to ask you to give me like 3 things that you think he did well and 1 thing that you think that maybe could be improved upon, because that's just supposed to help him, okay? So with that, Jack, it's all yours.
Work on. All right. Can y'all hear me okay on that? All right. All right, so like she said, my name is Jack Thomas, and today I'll be teaching the Statin Benefit Groups for hypercholesterolemia. So I wanted to start out with a little bit about me. So I'm a P4. Like she said, I'm on an academic rotation. While I was in school, I was the regional chair for SNAFA in charge of Perry County. And then I was also a scholarship chair for Kappa Psi. And I also did stuff with Phi Lambda Sigma. I've been working in community already for 8 years. I started out as a clerk, then a tech, and then an intern. And then I'm dual enrolled as well, working on my MPH. My rotations I've finished so far, I know that's still a good ways away for y'all, but it's important to be thinking about it constantly. So I started out and I did an international rotation in Japan, and then I did geriatrics rotation at the Tuscaloosa VA, and then I did my AmCare rotation at the Department of Health, and then I've been working on my academic. So the 10-week block for the AmCare and academic was really awesome because I got to be in clinic for all 10 weeks. So even though it was academic, I was still in clinic as well. So if you ever have any questions about the rotations, let me know because that's coming up faster than you think. All right, so my learning objectives for today. So we're going to start out. I want you to be able to distinguish between secondary and primary prevention, contrast statin benefit groups, and then given a case, I want you to be able to tell me if the patient fits the criteria for a statin benefit group. And then based on the criteria, if they do meet it, I want you to be able to tell me a basic therapy for them. So why is this important? Because it's always, when you get to therapy, it becomes much more real than in patho. Because you can actually think about patients that you've seen on your IPPEs and stuff like that. But a big thing is health fairs. So here in just a couple weeks, I'm pretty sure you'll be doing an IPA or IPPE, whatever, to learn how to measure cholesterol using the point-of-care testing that we use. And so, like, here's pictures of me and Hyan, who's a P3, in Perry County doing cholesterol checks for patients. And this is the machine that you'll be using, just to give you a little bit of a brief look at it. So it is really important because when you're doing cholesterol screening, you have to counsel on cholesterol. So it's important to know even the markers that she was just talking about, because you'll be seeing those patients constantly. And then in clinic, what percentage of your patients are hypercholesterol? A lot. And then on my geriatrics rotation at the VA, I had a lot as well. So these are patients that you'll be seeing constantly. And even if you look out on your IPPEs, you'll see them. Because I know, like on my IPPE, even for my flu shot clinic, I had a patient that was on a statin. So it is really important to look at and remember this kind of material. All right, so my outline for today. So I'm going to start out with types of prevention. Then we're going to move into a little bit of a statin review because I'm sure it's been a hot minute since you looked at those. Then we're going to move into contraindications and precautions that you have for statins. And then we're going to look at the actual benefit groups, which is going to be the bulk of the lecture, but still. All right, so getting into types of prevention. So you got two primary types, or you got two types of prevention. You got primary and secondary. And the whole goal is that you're trying to prevent an outcome from happening. And in this case, we're talking about atherosclerotic cardiovascular disease. I've got it marked down here, and Dr. Dugan talked about it in the last lecture, and we'll talk about it again in a minute. So you've got three of the benefit groups, which you can see at the bottom, that fall into the primary prevention. And this is the people that we're trying to prevent it from happening the first time, from it, happening at all. Then you've got the secondary prevention, are patients that have already had the event happen once, and we're trying to prevent it from happening a second time. So as you can see, there's only one secondary prevention group, which is the clinical ASCVD group, which is the first group we'll kind of talk about in just a minute. But we got to know what therapy we use first. So we've got statins. So you've got two primary types of statins you'll use with the benefit groups is moderate intensity and high intensity statins. And I've got a list here. So moderate intensity, just to review, from baseline is one that decreases the LDL by 30 to 50%. And then high intensity is 50% or higher. And as you can see here, it's pretty simple to memorize the high intensity statins because it's just atorvastatin or Lipitor, 40 to 80, and then it's rosuvastatin, 20 and 40. Knowing name brands is important as well, so you got Crestor and Lipitor. Just don't ever do like I do, and during the ASHP spelling bee, get Lipitor and spell L-I-P-T-O-R, and then get told Lipitor for the rest of your time at pharmacy school. So I got one guy, I don't know if any of y'all know him, but it's Greg Lockamy, and he literally every single time he gets a chance, Lipitor, right? So your moderate intensities are here as well. And if you can memorize the high intensity and the low intensity, then you know the moderate intensities as well. So it's whatever approach goes best for you, but knowing the high intensities is definitely the most important part. So now we move into the contraindications and precautions. So you got three main contraindications for statin use. You've got pregnancy, breastfeeding, and active liver disease. And we can kind of get why these are contraindicated because one, the statins cross the placental barrier, and they get into the breast milk as well. And then they're working in the liver, so we don't want them to be affecting any patient with liver disease. So again, pregnancy, breastfeeding, and active liver disease. Then we've got precautions for predisposing factors for adverse drug reactions. And I've got these on this slide. So you've got age over 75, an unexplained ALT, which is one of your liver enzymes, over 3 times the upper limit of normal. And I've got as many abbreviations across the bottom of the slides as I can, because that was one issue that you constantly Google blah, 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 medical abbreviation, and it's just popping up, and you're trying to see, is it that one or that one? And it just happens constantly throughout therapy. So I'm trying to limit that as much as possible. And then you've got history of previous statin intolerance. You've got Asian ancestry, and you've got any type of significant drug-drug interaction with statins. And I'm sure Critton Scott hit those, and you loved it because she's all about the sips, right? All right. So we're going to move into the actual statin benefit groups now. Now, on this slide, I've got an actual image of the flow chart from the guidelines, as you can see here. And this is what we'll be walking through pretty much for the rest of the lecture. So we'll put this on Moodle so you can see the full image.
It's already up there.
Okay, so it's already on Moodle. So if you want the full image where you can zoom in yourself and all that, you can. But we're going to be walking through it because when you first start looking at guidelines, it can be extremely confusing. And it really helps to know how to think about how to look through a guideline. So here's the 4 benefit groups that we have. So we've got clinical ASCVD, LDL over 190, diabetes, and ASCVD risk score over 7.5%. And so we'll be talking about each of these groups, and then I'm going to have 2 simple cases for each one. Well, not simple, 2 cases for each one. And I guess we'll just get started. So the first group we have here is clinical ASCVD. Now, I've got it in this order because it's a flow chart. Once you fall into one group, you stay in that group, you don't progress. So I'll talk about that later on when we get further down the line. But the first one we're going to talk about here is the clinical ASCVD group. So this is the group of patients that is that secondary prevention I was talking about, they've already had the outcome we're trying to prevent. They're at least 21 years old, and they've had this event. And just for a refresher, the ASCVD is atherosclerotic cardiovascular disease. You're going to hear me say that so much, you're going to be sick of it. You're going to be studying, you're going to be sick of it. It's going to happen a lot. Then you're going to get on your APPEs, and you're going to be like me, and you're going to forget to calculate the risk score at the time. So, so what is clinical ASCVD? So these are any type of outcomes or disease states that happen due to the atherosclerotic cardiovascular disease. So you've got ACS, you've got history of a myocardial infarction or heart attack. You've got stable and unstable angina, which is the chest pain. You've got coronary arterial revascularization, which is kind of hard to say. And that includes things such as CABG, which is coronary artery bypass graft. It's your bypasses. You've heard of single, double, triple, quadruple bypasses. PCI, which is percutaneous intervention. And these are the things that you hear about people being rushed to the cath lab. You hear them being put into surgery real quick after a heart attack or any type of event that it involves the heart. So then you've got CVA or stroke, and then transischemic attacks or TIA, and then you've got peripheral arterial and peripheral vascular disease of atherosclerotic origin. So it's a long, extensive list, but all of them involve the heart, and they all involve this disease state that we're talking about with hyperlipidemia. So,
Jack, if I could just interject here for a second.
yes, ma'am.
I just want everybody to know you do need to know those medical abbreviations. All right, they will be used on the exam, and you'll see us use them in the cases. So I don't want you to be on a test and not know what UA is. Okay?
Yes, ma'am.
Sorry.
Can you restate what CABG is?
Yes, ma'am. It's coronary arterial bypass graft. And so, like I said, that's like when you hear about the double bypass kind of thing. And PCI was percutaneous intervention. So that is typically where they kind of go up through the artery and they do angioplasty where they blow up the balloon to kind of get rid of the clot or the blockage in general. So that's what those are stand for again. No problem. All right. So like I said, this is an extensive list, but it's important that you have it memorized. All right, so once we've determined this patient is at least 21, and we've determined that they've had one of these events in the past, we then break them off by age. So I've got the levels of evidence here, and Dr. Dugan talked about these last class. So 1A is we've got enough evidence that we should do this. And then 2B is we have enough evidence that this should be considered. Now, for our purposes, we're going to be using it. So we'll be splitting them off into the two groups. But it's always important to look at the level of evidence when you're trying to interpret future therapies in general. I constantly have to read the guidelines during rotations. You're doing topic discussions on heart failure, and you're having to read the different classifications because the heart failure guidelines change between when they taught them to you and you have to do your topic discussion. It just happens. So for patients under the age of 75, we're going to use a high-intensity statin. And those high-intensity statins, just to kind of review again, were atorvastatin and rosuvastatin. Atorvastatin 40/80, rosuvastatin 20/40. Again, those are two things that you should kind of have ingrained in your head and you'll be sick of. If you're over or equal to the age of 75, though, we give a moderate intensity. So like I said, once you determine they've had an event, you then look at their age, and then you break them down by their age if they're over 21. So I've got a couple of little cases here. So again, like I said, I've put as many of the acronyms down at the bottom as I can. If there is one that I forgot, just raise your hand and ask, because I can tell you. So we got a 55-year-old African-American female with past medical history of stroke 2 years ago. So the question is do they meet the criteria for a statin benefit, for the ASCVD benefit group? Yeah? And what intensity statin would you give them? High? Okay. Yep. Oop. Do I not have that slide in there?
Well,
Did you open the student one?
I might have, yeah.
Give me just a second, y'all. I'm sorry.
Sorry about that. My bad. Not his.
Yep.
The question is, do I have the right one even on that deck? Because
Yeah.
I might not. Sorry.
No. That's one reason I put it on my slide.
I'm bad. Sorry. I thought I had the right one.
Yay.
That must have been the one I tried to insert it with insert. Sorry about that, Jack.
Mm-mm.
Statin won't help high blood pressure. It'll just stop the heart attack that happens after the blood pressure.
All right. So like we said, yes, they do meet the high intensity group, or they meet the criteria for the group, and they get a high intensity. So the second patient is a 78-year-old African-American male, past medical history of cabbage 1 year ago. So do they meet criteria for the group? Yeah. And what level statin would you give them? Moderate. And why is that again? Got it. Yay. Yeah. What are you with? What's wrong? All right. So I'm going to pause just here for a second for any questions because that's a lot of material all in once. So just to review again, so the clinical ASCVD group is a patient who's already had a heart attack, a stroke, they have peripheral arterial or vascular disease, they've got angina, or they've had one of those type of interventions done. Yes, ma'am.
So why would you give someone that is 70, well, over 75 a moderate intensity? Because I thought you were trying to decrease the progression.
Yes, ma'am. All right. So her question is why would you give patient?
High intensity, so you want to.
Yeah, it's a great question. So her question is why would you give a patient that's under 70 or over 75 a moderate intensity? The evidence currently shows that patients that are over 75 are at higher risk for ADRs. And so that's one of the reasons we're kind of looking at it. It's, what's that?
Nothing.
I'm sorry. Okay. Yeah, so that puts them at higher risk for adverse drug reactions. And evidence is just showing currently that it's probably not as good an idea to put them in the over 75 for on a high intensity. So does that kind of answer your question? It's a good question. I really appreciate that. All right. All right, so like I said, so they've got one of those events that happened. They're over the age of 21, and then we break them off at 75. So the next group we're going to talk about is the LDL over 190 group. And so, like I kind of said earlier, this is a progressional type thing. So if you got a patient whose LDL is 210, but they've had a heart attack in the past, they fall into the clinical ASCVD group, not the LDL group. So we'll talk about that again in a second because it, yeah. So, and I'm going to hit it multiple times because it is important. It's a progressional type line of a flow chart for this. Once you're in the one benefit group, you don't progress into a different one. So if you've got a patient with an LDL of 210 who's had a heart attack in the past or had a stroke in the past, they're in the clinical ASCVD group, not the LDL over 190 group. Do what? Would you say? Yeah, pretty much. Come on.
Just to clarify, guys, he's telling you how to think through this, okay? The reason they don't progress down is because a patient that's already had a heart attack is at the highest risk for having a second event, right? So even if they have an LDL greater than 210, that doesn't eclipse the fact that they've already had a heart attack. So you treat them like they're in the clinical ASCVD risk group, not like they're in the risk group for LDL greater than 190. By the same token, if you had a patient, and he'll talk about this in a second, that's had a heart attack or they've had a stroke and they have diabetes, all right, well, it's bad that they have diabetes. That increases their risk. But they've already had an event, okay? So we have to treat them the most aggressively. So you can think of this chart in terms of how aggressive is the treatment. That's another way to think about it.
Thank you. Sorry, it's a difficult concept to kind of get across. Like during our year, I didn't really even realize that until I started restudying it during a topic discussion. And I've talked to a lot of people in my class that didn't even realize it. So it's a very important part of this therapy and progression. Can y'all still hear me okay with this right here? Good. I don't hear my echo too, so that's awesome. All right. So the next group, like I said, is LDL over 190. So I've got levels of evidence here again, and as you can see, it's 1B and 1B here, which is another one of those. We have enough evidence that we should do this. For our purposes, again, we will be doing this. So this is age over 21, just like the last group. They don't have a clinical ASCVD, and the important part with this group is that we need to evaluate them for secondary causes, because we don't want to just jump straight to giving them therapy if there's a reason that they're having this issue. So what are these secondary causes? So I know this chart's kind of extensive, and it's definitely important to have an understanding of this, but we're going to focus mostly on the drugs here because as the pharmacists, we're the drug experts. You're going to be the drug expert. So it's going to be important if you've got a patient that you're looking at to be able to tell if whether or not one of their drugs is causing the issue that you're trying to treat. Because you've heard you don't want to give a drug to treat a side effect of another drug. You want to limit it as much as possible. So in this list, we've got diuretics, cyclosporin, glucocorticoids, amiodarone. And for the most part, these are hitting the liver. And like we said, where statins work is in the liver, and that's where cholesterol is made. So it kind of makes sense that it's going to be increasing the cholesterol as well, on top of glucocorticoids causing the weight gain and all the other problems that they have. Amiodarone being processed in the liver, and then it can also cause hypothyroidism. That's a little bit beyond what y'all need to know at the moment, but just to give you more rationale for why. All right. For elevated triglycerides, we've got oral estrogens, bile acid sequestrants, protease inhibitors, retinoic acid, which is vitamin A derivative, anabolic steroids, sirolimus, and other things. So again, the big take home here is that it's drugs that are affecting the liver. So this is not an extensive list. I don't expect you to have it completely memorized, but it's definitely important to know. So moving on from that, once you've got a patient whose LDL is over 190, they're at least 21 years old, they don't have any clinical ASCVD, and we've evaluated them for secondary risks, and we have no other, or secondary causes, and we have no other explanation, we treat them with a high-intensity statin. And so, got a couple of cases here. So patient 60 years old, African-American male, LDL 250. Do they fit into the benefit group? And just assume if I don't have anything there, then there's no secondary cause. Okay, and then what stat would you give them? High intensity. Yep. All right, you got a 39-year-old white male with an LDL 68. Do they meet the benefit group? No? That's because their LDL is too low. So they're not indicated for therapy currently. Yes?
If you have a patient that does not have an event happening and they are LDL over 190, they are 75 and above, do you use a high intensity or do you use a moderate?
Currently, we use a high intensity. So the question was, does this split off into age as well? And the answer is no. If they're over 21, then currently evidence shows we use a high intensity despite age. But it's still a precaution that you look at. So if you've got, so Dr. Dugan will talk about later in statin myopathies and things like that, that it's still a precaution. All right. Are there any other questions currently? Yes, sir.
This might be a stupid question.
There's no such thing.
So, I mean, we're talking about secondary causes of hyperlipidemia.
Yes, sir.
What did we say was the primary?
What we say is primary?
I missed that.
So it would be overproduction of cholesterol in the liver, or it would be their diet. So that's what we're really looking at. There's other things, like the secondary causes are things that we're not trying to treat that could cause the elevation. So primary would be the main reason it happens. Secondary would be something as a side effect almost.
So someone's primary could be the secondary listed. Is that what you're saying?
No.
What is that? Secondary, that's not.
What's that?
You said the primary could be diet or like your body's like genetic overproduction of
Mhm.
cholesterol, but that's a secondary cause. That's-
Well, yeah. For secondary cause for triglycerides, wasn't it? Was it LDL as well?
Oh, I don't know. It's like a category.
Don't overthink this. Okay? Primary means first cause. Okay?
Oh, I see what
Even
you're
if
saying.
it's diet, even though it could be like the food you're eating, but it's the fact that your body isn't processing the food correctly. So it's still primary. It's pathophysiology that's causing the problem. okay? So primary means your body is causing it. It's something your body doesn't process well. Secondary means it's something else going on. We've given you a drug that's causing the problem. It's not endogenous to your body, okay? That's how to think about it, all right?
Correct. So yeah. So diet's actually what you're eating. So if you're eating McDonald's every night, triglycerides could probably be pretty high just from that. All right. Yeah. Yeah, exactly. And as for our primary, like, that's also a point of current research. Like, we're still trying to determine areas that are the rationale for primary. So that's the reason we've got new drugs still coming out for treatment. All right. That is interesting. All right. All right, so we've talked about clinical ASCVD, and we've talked about the age on it is 21, and it includes heart attack, stroke, peripheral arterial vascular disease, and then angina. We've got LDL over 190, and again, it's the same age as 21, and we have to evaluate for secondary causes. Now we're going to move into diabetes, which, as you can see, the age is going to change on this one. So again, just to reiterate, if you have a diabetic whose LDL is 210, and they've never had any ASCVD, then they would be in the LDL 190 group. And if you have a diabetic who's had a heart attack when their LDL is even elevated, then they're in the ASCVD group. So diabetes is patients that are 45 to 75 years old, and it's type 1 and type 2 diabetes. We evaluate them for clinical ASCVD, and then we look at their LDL, and we determine that they're not over 190. So as you can see, we're still progressing down the chain here. I didn't throw it out on the last one, but so this is where we started. This was the second one, and this is the third one we're on now. So if you want to look at this, if you want to look at the big image when you're studying, you can kind of refer back to where we are on it. All right. Now, like the first group, like the clinical ASCVD group, this one gets broken down into two separate treatment paths. But instead of age, we're using the risk score this time. So we look at their ASCVD risk score, and if it's under 75 or 7.5%, then we use a moderate intensity statin. And if it's greater than or equal to 7.5%, we use a high intensity statin. And you remember the ASCVD risk score, what Dr. Dugan talked about last class, and she talked about using the website for it. Well, there's also an app for it, and you can download the app. It's a little bit slow to start up, but it works pretty good. I use it in clinic literally every day. Do what? You'll be given the ASCVD risk score on the test. You don't have to calculate it. You had your math test already. What you laughing at? Yeah. Yeah. All right. So, like I said, this group gets broken down by the ASCVD risk score. 7.5% is kind of the cutoff there. And then I've got a couple cases on this one too. So I got a 41-year-old white female with a type 2 diabetes. LDL is 141, and the ASCVD risk score is 5.5%. So do they meet criteria for this benefit group? Yep. And what level statin would you give them? Moderate? All right, that's correct. And the reason is because their ASCVD risk score is under 7.5%. All right, so we got another case, 53-year-old African-American male, type 2 diabetes, LDL 170, risk score is 8.5%. Do they meet criteria? Yes. No? Be contrary, do it. Why do you say that no? What's going on? Yeah, so the LDL cutoff is 70 to 189. And so this patient fits the group because they're in between the age of 40 and 75. They have an LDL of 70 to 189. They don't have any clinical ASCVD in the past. So they meet the group. So this next patient, 53-year-old, like I said, and what level statin would you give them? Yay. We clap. Golf clap.
This is the hardest one.
Golf clap. Yeah, golf clap. That's right. Do you have a question?
Yeah, okay, so I understand that you don't progress down the line.
Mhm.
If you have diabetes and then have a heart attack,
Mhm.
would you be in the diabetes or would you
Clinical ASCVD.
so then you would jump
Mhm.
other things?
Yeah. So her question was, if you have diabetes and then you have a heart attack, you're now in the clinical ASCVD group.
So you jump up to like higher risk.
Right. So if you were on a moderate intensity, then you would, if you were under the age of 75, then you would move to a high intensity. Right. So yes, like his question. So just like the LDL group, if they're over the age of 75, these patients still get a high intensity. It's just one of those one of those precautions that you look at. And like I said, Dr. Dugan will talk about myopathies and statin risk and all that kind of stuff in a later lecture. So, are there any more questions? These are some awesome questions, guys. All right. True story. We got a very humble person here. I feel the same way sometimes. Okay, so this one first, then I'll get over to you. Yes, ma'am. Hmm.
What if you have a diabetic who is less than the age?
Less than the age? Less than 40?
What do you think?
So for them, they're not indicated for the high intensity statin yet. So you would wait until they're 40 to reevaluate. Not yet.
Like, don't do anything with him.
I mean, you've got other things you do, but not for this. Not for the. Correct. It's not for the purposes of this. Yes, ma'am.
Wait till
So,
next fall.
yeah.
That question.
Yeah. So, like her question was, if you had a patient that was under 40, would they get a statin at all? And the answer is not yet. So you'd reevaluate at the age of 40. And like Dr. Dugan said, yes, next fall you get to have a lot of fun. We just finished it. I was literally helping people study as much as I could. Like, I was up here on Sunday for like 10 hours, and then the night before test, I was here till 10 o'clock. And Dugan was, you were up here till 9:30 the night before test, and answering emails all the way into the morning.
It's a long night.
And it's a very difficult test. It was good. Don't scare. No. You're the one that started it. You started it. All right. Yes, ma'am. What was your question?
I was just kind of on the other spectrum of that. So if they're over 75 and have diabetes, we don't do anything either related to that.
Correct. Right now, we don't. So. Now, if they're 40, so her question was, if they're over 75, do they get a statin? And the correct answer is not yet. So unless they have something else that happens where the LDL increases or they have a heart attack or something like that. Or the next benefit group after. Yes, ma'am.
So, with the treatment groups and stuff, you can't move down, but if you're like in a lower group, you can move back up if you like have that.
Right, because it's all about the intensity and the risk. So, so a person who's had a heart attack in the past is at higher risk than a person who just has diabetes.
I just want to make sure you touch on those.
Right, and I know that's really confusing, but yeah, and like her question was, is you can move back up if you have something that happens that puts you in a higher risk group. And like Dr. Dugan said, the progression is a risk thing. So the clinical ASCVD is the highest risk group. All right, so just kind of go through back in. So we got the clinical ASCVD, and which includes heart attack, stroke, angina, one of those cabbage things. It's always fun to say. And then they've got to be at least 21 years old. Then you've got the other group, which is the LDL over 190, who also has to be 21 years old, and you have to evaluate for the secondary causes there. Then you've got diabetes, which includes type 1 and type 2, and they have to be between the age of 40 and 75, which is different than the first two groups. And then you've got the next group, which we're going to get into, which is the ASCVD risk score over 7.5% group. All right, so these patients, again, are aged 40 to 75, just like diabetes. They have no diabetes, they have no clinical ASCVD, and their LDL is between 70 and 189. And these kind of exclusion things make sense when you look at the progression of intensity. So when I learned it, we just knew 40 to 75 and no ASCVD, and we were like, okay. So I'm trying to help out as much as I can on determining the groups. So these patients, this is a 1A level of evidence, which means we should do it again. If their ASCVD risk score is over 7.5%, we look at the presence of high-risk markers to determine if they get a moderate or a high-intensity statin. And so these high-risk markers are right here. And so this includes ASCVD risk score over 20%, LDL over 160, family history of premature ASCVD, that coronary artery calcification thing. It's another interesting thing to say that I slip up on. You got elevated high sensitivity C-reactive protein, which is a biomarker for inflammation. And I've got as many of the acronyms at the bottom again as I can. And then HIV, CKD, chronic kidney disease, and then chronic inflammatory disorders, which this kind of pairs up with the HSCRP, like I said, because it's a marker for inflammation. So this is another list you got to memorize. Hidden list is great. Yes, ma'am.
What did you say that the high sensitivity C-reactive protein is called?
It's a biomarker for inflammation. So just an example, like, and this is not something for the test, just to kind of cement it, but like rheumatoid arthritis patient who's in the middle of a flare-up, their HSCRP is going to be high. All right. So based on these risk markers, if they have at least one of these, then they get a high intensity, and if they don't have any of these, they get moderate intensity. So a couple more cases. 43-year-old white female with an LDL of 131, ASC risk score of 21%. Do they meet benefit group? Yeah. And what level of intensity stat would you give them? All right. Why would you give them moderate? Okay. What about the risk score? Okay. It's 20. Yeah. See? These two work great together. Too bad we can't do group tests all the time. Dude, I wish, but nah. When you're in clinic, you can't do group things as much. All right, so like I said, so yes, and it's a high intensity. And the reason they're high intensity is because the ASC risk score is over 20%. All right, next case, 70-year-old African-American male with an LDL of 172, ASC risk score is 6%. They meet criteria? Why? Okay. Why not? That's it. Their risk score is below 7.5%. See, these two work great together. Two halves to a whole. So they're not currently indicated for therapy. Yes, sir.
Is the risk score good to like a scale like to 100%? Like what is it typically like? What do you typically see? Like, what's the highest?
What's the highest you've seen? I think the highest I've seen is like 30%. Yeah.
I think I've seen 42, but only once.
So he asked what was the high, like the risk scale, like what's the highest we've seen? Like it is, I mean, it's a percentage, so it's correlational, not causational, because it's relative, and it's 0 to 100%. The highest I've seen is like 30-ish. She said she's seen 42%. So, yeah. Yes, ma'am.
So to be in this category, you have to have like 7.5% or greater.
Mm-hmm.
And then you look at the risk markers. Is it like on the list markers? Is it so if it's like greater than those, that's high, but if it's less than those, it's moderate?
Yes, ma'am. You got it. So her question was, just to reiterate, so these risk markers, oh, right into the, great. So she said, like, if you meet these criteria, you get a high intensity, and if you don't meet these criteria, you get a moderate intensity. So that's kind of what she was reiterating. All right. So we talked about clinical ASCVD, talked about LDL over 190, talked about diabetes, and we talked about ASCVD risk score over 7.5%. Yes, ma'am.
So you only have to use one of the high risk ones.
Yeah. So like she asked if you only have to meet one of them, and that's it. Yes, ma'am.
You said that you can progress up in the scale if you choose one of those things. What if, like, if I was originally in the LDL category and I got my LDL down lower, would I move down?
No,
You stay there because I'm staying on statin therapy.
you stay in there because you're still high risk. It's one of the. It's kind of like once you have diabetes, even if you get your A1C below blah blah, you're still diabetic, right? Especially if you're being treated for it. So if you make lifestyle changes or if you make a medication change, then it was lowered because of that. Because I got plenty of patients whose cholesterol are fine now, but you look at them and they're on atorvastatin 40 milligrams. Yes, sir.
In terms of these benefit groups, what's the purpose of the low intensity statin?
So low intensity statin isn't used pretty much anymore. It is used in cases where you have a patient who has had a problem with a level of intensity statin, and then you retry the statin and you try to lower intensity. So it would be for patients who were at the higher risk but still needed it. And if you've worked in pharmacy, you'll know you don't see it very often. You see a couple every now and then. You'll see like the 20 milligram pravastatin, and they'll be like, okay, why are you on those? Yeah. But yeah, so the important thing for benefit groups is to memorize the moderate and high intensity statins, though. And you can kind of ration out the low intensity from there. All right. So to kind of finish up, I gave a little bit of a summary slide for study purposes because these are always great. They make things a lot easier sometimes. You got 30 pages of packet or you got one sheet of paper. So just to kind of explain this, like we talked about with the benefit groups, as you're going down, you're meeting one of the groups. And as you go across, you're finding the criteria and the treatment. So, and like this is not an all-exclusive or all-inclusive list, but you kind of progress down, over for criteria, and then over for treatment. So I hope this kind of helps with study purposes. But that's about it. Does anybody have any more questions before? Y'all had great questions. Okay.
So if y'all would just take a second and write down 3 things that you think Jack did well, and if there was something you thought he could improve on, if you'll make a note of that. It'll just help him in the future. While I switch out USB drives again. It's not your fault. All right. So everyone, we have our first case that we're going to do. If I can find the... There we go. That's what I'm looking for. All right. So we're going to our first case, if I can get this to open. It's being very slow. Please, open. You can do it. Come on. Thank you. There we go. All right, so everybody look at Miss JD. Okay? This is one of the cases. You should have it up on Moodle. So what I want you to do, we're gonna read through the case here in a second, but I want you to pick, I don't know, 2, 3 people that you want to discuss everything through. And what you're gonna do is I'm gonna give you a certain amount of time for you to solve this case and answer the questions. And then we're gonna come back together and we're gonna discuss it, okay? So find 2 or 3 people that you want to work with. So let's talk about this case. All right. So Miss JD is 62 years old. It's an African-American female. She comes in secondary to a hospitalization at UAB for an MI, and that was 1 month ago. Her past medical history is significant for hypertension, dyslipidemia, and insomnia. Her current medications include amlodipine, Maxide, which is a diuretic, which she uses for her hypertension. She's on atorvastatin 10, and that was started upon discharge from UAB. Trazodone 50 milligrams, and that's for the insomnia. We don't have any family history that seems to be contributing. Her social history, she doesn't drink and she doesn't smoke. She does have insurance, and it's Medicare Part D. Blood pressure today in clinic is 132/80. We look at her weight. She's 225 pounds. She has a waist circumference of 41 inches. Labs, everything was within normal limits. WNL, within normal limits. Everybody got that? WNL means within normal limits, except for serum creatinine, which was 0.9, and a blood glucose of 100. When we look at her lipid panel, total cholesterol is 195, HDL is 35, triglycerides are 111, and LDL is 138. So take a few minutes and answer your case. All right. Can't make it take it. And it should be. Yeah, so won't do it. Not so much for that. I don't know why it won't do it. It should work, but it won't work. Or I have to use the mouse.
Yep.
Oh, good grief. And if somebody hadn't walked off with the, because there's supposed to be a stylus in here. Yeah, they're supposed to be. That's where it's supposed to be. Yeah, I'm not gonna be able to write. Just don't understand why it's not. It should let me write. It should let me write. I don't know why it won't. Colors, right? You're right. I don't know. It should let me write. All right, about 2 more minutes, guys. About 2 more minutes. Just the first case. Yeah. No, it's all good. I mean, don't be wrong. You want to be overachievers, go for it. All right, let's come back together. Let's go ahead and come back together. All right, so let's talk about this case, okay? So the first thing is, does this patient fit into a benefit group? So do they have ASCVD? Yes, so right off the bat, we know they have clinical ASCVD. So then the second question is, what? What do we need to know to figure out treatment? Age. So are they older or younger than 75? Okay, if they're younger than 75, what statin intensity do we need? A high intensity statin. So which statin did y'all pick? Atorvastatin 40? Anybody pick anything else? Crestor, what? All right. Be at least Crestor 20, right? Okay. So you could have also chosen, completely up to you. This is one of those things where I discuss with a patient. It's because different insurance companies cover different things at different level of copay. So I can tell you with Medicare, with my mother's current, Crestor is about $130, all right, a month. So she'd probably want atorvastatin because it's a lot cheaper. It's in about a $20 a month copay, okay? So I really talk to the patient, and because any of the high-intensity statins are equally okay, all right? So I can start at the highest dose, or I can start at the lower dose of the high-end range. So I could start at atorvastatin 40, or I could start at atorvastatin 80. All of those are equally okay. What might make me think maybe starting at 40 with some patients might be a better idea? All right? If I have any indication that they might not tolerate the 80, okay? So if I have a patient that has a history of having a hard time tolerating statins, I might start at the lower dose before I jump them straight to the higher. Does that make sense to everybody? Okay? But it's really common sense as far as which statin that I need to use. For our purposes on the exam, all right, unless I give you some reason you can't, you can use any of them that you want to. Okay? I'll have to give you a strong indication, such as a drug interaction, all right, to make you pick a different one. Okay? And really, with atorvastatin and rosuvastatin, there aren't so many drug interactions that I panic about it. Simvastatin and lovastatin, they're a different story. We'll talk about them in a little bit. Okay. So what monitoring do we think we need to do? What would be the monitoring on a statin, do you think? We have to worry about the liver, right? Okay. So everybody watching for liver enzyme elevations. What else? Somebody over here mentioned it earlier when we were talking about doses. Muscle pain. Okay. I worry about muscle pain with statins. Not any muscle pain and not all muscle pain. I worry about muscle pain in large muscle groups that the patient can't explain. Okay? If you've started a new workout routine and you're walking like this, you know, what was that thing a few years before? Insanity, I think, was the name of the program. Has anybody ever done Insanity? Well, it's insane. Okay? Yeah, so P90X, there's another one. I had a resident who was trying to get fit for a wedding. She couldn't get out of the car. She's walking like this. You know, I was like, what did you do? Okay, that doesn't count as unexplained muscle pain, right? We know why she was in pain, all right? So, but you are looking for pain in big muscle groups, the thighs, the butt, the back, okay? Bigger muscle groups is where this is going to show up, and the patient won't know why it's occurring, okay? So bigger muscle groups. Okay. So with that, let's go ahead and go to the next case. This is JW. This is a 51-year-old African-American female. She has hypertension and type 2 diabetes. She's on amlodipine 5, hydrochlorothiazide, and metformin. Father died of a stroke at 63. Mother's alive and well. She also has diabetes and hypertension. Her sister's alive and well, has hypertension, diabetes, but she had an MI at the age of 59. She's insured by United Healthcare. Blood pressure is 118/82. Weight's 205 pounds. Waist circumference is 40 inches. Serum creatinine is 1.3. Blood glucose is 170. Total cholesterol is 186. HDL 58. Triglycerides 205. LDL is 87. And A1C is 9%. That just means the patient's diabetes is not well controlled. All right, so take a few minutes and answer these questions. 2 more minutes. God bless you. That's it perfectly. That's exactly how you do it. That's exactly how you do it. All right, let's talk about the case. Let's talk about the case. All right. So did everybody see here? Everybody said, well, this patient has diabetes. Don't we need an ASCVD score? Yeah. So I just went in, I Googled ASCVD risk score calculator, this came up, and I plug and chug. You put in the numbers, and it gives you a risk score up here. Everybody see it? So for this patient, it's 5.5%. So what does that mean if it's 5.5%? So first question is always, every single time, be very disciplined, all right? Because right now it's easy because we're just going through these cases, right? On the exam, you have to be really disciplined in how you think about this. So the first question is, does this patient have ASCVD? No. Does this patient have an LDL greater than or equal to 190? No. Does this patient have diabetes? Yes. Okay? Every single time, because otherwise you'll skip a step and you'll put a patient on the wrong treatment bucket. Okay? So they have diabetes. So then the next question is, what is this patient's ASCVD risk score? All right? So it's 5.5%, right? Because we calculated it. So if it's 5.5%, does this patient need a moderate or a high intensity statin? A moderate intensity statin is correct. So what did you all pick? Orvastatin 10, perfectly acceptable. You could have done Pravastatin 80, also perfectly acceptable. How about Simvastatin 20? Just fine, okay? Any moderate intensity statin is fine, okay? Y'all see how that works? You getting a feel for it? All right, because this is exactly the kind of thing, y'all want to hear this next statement, trust me you do, okay? This is exactly the kind of thing you're going to have to do on the exam. What I'm showing you to do right here with these cases, this is what you're going to have to do on the exam, okay? So let's do the next case. Anything else that we haven't talked about? Let me look here. Nope, we talked about that. Monitoring's the same. So liver function tests, signs and symptoms of rhabdo, i.e. that muscle pain. The other one I mentioned the other day, which is we don't want the patient's LDL to go less than 40. And given this patient's LDL is starting out at 87, all right, that's definitely something that we want to watch out for. Make sense to everybody? So that would be the other monitoring parameter. Okay. You found it. Jack, thank you. I couldn't find this to save my life. All right. Where was it?
I think that's the organizer.
It was underneath the organizer. Well, why didn't I think of that? All right. Right. You will understand that joke more later when you come visit me in my office. All right. So let's look at Miss T.O. How are we doing on time? We're okay. All right. So she's a 59-year-old white female, and it still won't write. Why? It hates me. Okay. 59-year-old white female comes in today for MTM follow-up. She's got dyslipidemia and hypertension. Medication, she's on lisinopril and chlorthalidone for her hypertension. Family history, the father has hypertension. The mother had an MI at 67. You can help me. You can fix me. Fix me. I want to see what you do so I can fix me next time. I was going to say, in 1409, I got this to work. No? It just hates me. I'm telling you, it just hates me. All right, what did you hit? Uh-huh. Okay. All right. Thank you. Appreciate it very much. Thank you. Everybody, a round of applause for the technical support. All righty. If I could, I would. Unfortunately, it's not my class. All right, so anyway, she smokes a half a pack a day. All right, she's insured, follows no prescribed diet. Let's see. Blood pressure is 114/74. Weight's 151. Total cholesterol is 235. HDL is 45. Triglycerides are 136. And LDL is 163. So go ahead, take a look at this patient and work the case. All right. Does anybody need any additional time? No? Okay. So, first question. Does TO have clinical ASCVD? No. Does TO have an LDL greater than or equal to 190? No. Does TO have diabetes? No. So then what do we need to do? We have to see if she fits in the ASCVD risk score group. So we have to run a risk score. What risk score did y'all get? 9%. Okay. So does she fit into the clinical ASCVD risk score group? Yes. Okay. So then we have to decide whether or not it's going to be a moderate or a high intensity statin, right? Does this patient have high risk markers? She does? What is it? LDL greater than 160. All right, very good. So what do we start? A high intensity statin, right? So what would be an example of a high intensity statin? Rosuvastatin, Lipitor, could be 40 or 80 milligrams, rosuvastatin 20 or 40 milligrams, right? Okay. Do y'all start to feel more comfortable with benefit groups and how you think about that and how you pick therapy? I hope so, because that was the goal of all this. All right, let's see. Let's see here. Anything else that we wanted to talk about? I'm sorry, who? Yeah.
This one, would you do lifestyle changes since she has the family history?
Okay. So the question is, with the family history and with her diet, wouldn't we also do lifestyle changes? The answer is yes, I always do lifestyle changes. Okay? If there's any room in the lifestyle to change it, we're going to change it. All right, or at least try to change it. How's that? All right, any other questions? Sorry, these lights get bright up here. Sometimes I'm blind anyway. All right, let's see. Anything else there? Nope, we need to monitor the same things. That's about it. All right. So what questions do y'all have about the benefit groups today? And about identifying patients? Everybody gets how you think it, right? Because that's important. Because I assure you, some of you, as you get practice at this, are going to start skipping steps. And when you skip a step, you're going to put a patient in the wrong benefit group. So be very disciplined in how you think about that. Okay? No questions? All right. Have a great day. Have a wonderful weekend. Oh, I will send it an email. It'll be better anyway. That didn't sound good. Hey. Oh. Hey, everybody. If you have the feedback for Jack written down, if you'll just bring it forward. If it's in an electronic format, if you'll email it to me, that'd be great. Thank you.